The purpose of this episode is to explore common health and well-being issues for people with Down syndrome. This content is not intended as a substitute for direct medical care by relevant professionals. Rather, we hope to share new and important information so families and supporters can be well informed when accessing medical care. Your individual's medical or educational professionals may have recommended different practices or procedures that are specific to them. Do not modify or change your individual's treatment or therapy plan without consulting with your care provider.
Today on the LowDOWN, a Down syndrome podcast, Dr. Jonathan Santoro and Dr. Eileen Quinn gives us a lowdown on Down syndrome and regressing, and Cindy Harasen shares her family story. Over to you, Hannah Marla.
Thanks, Danielle. Hello, everyone, and welcome to the LowDOWN podcast. My name is Hina Mahmood, OT at the Down Syndrome Research Foundation, and I'm joined by my most fabulous co-host and colleague, Marla Folden, who is a speech therapist at the DSRF. Hi, Marla.
Hi, Hina.
How are you?
I'm doing well. Are you ready for another episode?
Ready for another episode. Yeah, this is a really important one. So we're excited to kind of get into this topic with our guest today. So today we will be speaking with a wonderful mom who has experienced something that every parent dreads, their child regressing and losing skills. Regression in Down syndrome is receiving a lot of attention in the medical and research literature as the incidences of regressive episodes, unfortunately, seem to be increasing, or we're just becoming more and more aware of them, especially in the face of something like the pandemic. So later in this episode, we will be discussing regression in Down syndrome with two world-leading experts. But first, we feel it's really, really important to understand the impact of regression from a parent's perspective. So we will be joined by Cindy Harasen, and Cindy is a stay-at-home wife and mother of 3 adult children, ages 23, 21, and 18. Her youngest, Kaylee, has Down syndrome and is the only one still living at home. They live in rural Thunder Bay, which is a city in eastern Canada, in an off-grid house on top of a mountain. Cool. So Cindy has homeschooled all of her kids, including Kaylee. And Kaylee became ill last summer with Down syndrome regression disorder, which will be the focus of our discussion today. So welcome to the LowDOWN, Cindy. Thank you so much for joining us.
Thank you for having me.
Great. Okay, so in the tradition of the LowDOWN, we like to start off our podcast with 5 secret questions, just to get to know our guests as people first, before we kind of get into the serious discussion. So would you be game for that?
Sure.
Awesome. Okay, so I'll get started. Question number 1, what are you currently reading or listening to?
Okay. My reading lately is really focused on medical research. So there isn't a lot other than scrolling through Facebook mindlessly. There is no other sort of reading for enjoyment right now. Listening to, we're big fans of contemporary Christian music. So we listen to our local Christian radio station. And that's just sort of the genre that we enjoy.
Fantastic. Awesome. Great. Okay. Question number 2. What is your go-to self-care routine?
Oh man, these are tough. Sorry.
No, that's okay.
Again, this is a bad year to be asking me these
questions.
I
was thinking that, yeah.
I'm thinking, seriously, Netflix, midnight, the house is quiet. Bluetooth, headphones on, a show that, is predictable, that I know the pattern. That's where I can kind of just clue out. I don't know, escape for an hour at the end of the day before I go to sleep. And I don't actually recommend sort of screens at the end of the day before you go to bed. But that right now is sort of my only little piece of enjoyment and sanity. And carbs. Carbs.
Yeah,
I'm with you.
Yes.
Yeah. I was going to say, it doesn't matter. You have to do what you have to do to take care of yourself. So if that's screens at midnight, then that's screens at midnight. Totally get it. Yeah. Okay. I'll let Marla take over for the next few questions.
My next question for you is, what's the most unexpected thing about living on a mountaintop?
I mean, it's a small mountain, but the off-grid part was that there was a bit of a transition there because I left my microwave behind. I think that was probably the thing that took a bit of adjusting. I left my Keurig behind, and that was just sort of consciously trying to use the least amount of power that we could.
Sure.
So, and now I use a small French press rather than having that Keurig plugged in and that hot water all day long. I do all of my cooking on the stove or warming up in the stove. There's no more sort of nuking that cup of coffee 10 times during the day.
Guilty.
So those have been some little, those are some little changes, but otherwise it's wonderful.
Oh, good. I think a lot of people are curious about that kind of thing. So thanks for indulging us in that. Last question is, what's one skill that you wish everybody had or you think everybody should have?
A skill, not a characteristic, but a skill. Cooking, I think that sometimes I think marry someone who's a mechanic or marry someone, right? Like everybody should have someone in the family with those skills. I'm thinking a chef, like cooking, being able to cook.
I mean, it's kind of an everyday thing for most people. So if you can cook well, that's a great thing. Totally. Yeah. Let's talk about Kaylee. Let's get into it a little bit here. Could you tell us about Kaylee and her personality, what she liked and what she was interested in before she was sick? If this is too upsetting, then don't. But,
no, I can talk and cry at the same time, so I'm not going to worry about that, if that's okay.
That is fine.
She was very active. She was a cheerleader with a special needs cheerleading group.
Awesome.
She was a competitive swimmer with Special Olympics. She did Special Olympics, rhythmic gymnastics, track and field. I'm sure there were other things. So she was always doing something. She was very active, very athletic. We always have joked about she's the healthiest one in the family, very fit, sassy, funny, chatty to the point where you're like, can you just stop talking for like 1 minute, please? And she'd be like, one more thing. Really the joy and spark in our life.
When did you notice that something wasn't right? What were your first sort of inklings that like, this is weird?
Yeah. And I mean, hindsight, right? Like we can look back now and analyze, and probably there were signs before we realized that they were signs. But I think that the really extensive increase in her self-talk, she was, somebody who had, self-talk was always something that she did to a pretty high degree, but it began to escalate to the point where we were really having a hard time engaging with her, that it wasn't just self-talk. She was really in her own little world. And again, we didn't know at the time really what was happening. We were trying daily to sit her down and have a conversation time so that she would focus on us and connect and answer questions and share with us. And that was just getting harder and harder and harder to do. There were other things happening. Again, we didn't know at the time. She wasn't sleeping. Like she was always a night owl. So, we didn't see that as immediately a sign of something that was wrong, but there were more and more nights where she would be wandering the house at like 1 o'clock, 2 o'clock in the morning. Her creative, imaginative play escalated. Again, she always liked to dress up. She was always, she loved her movies and the characters in the movies, but but it began to escalate to a point where, again, we weren't sure what was going on, but it was like it crossed a line, and it was becoming a little bit too extreme.
Could I ask you to describe her self-talk? Was it, did it have any characteristics to it? Was it positive self-talk? Was it negative self-talk? Was it a mix? Like, could you characterize it as like a different kind of self-talk, or was it the volume of it?
No, there was no signs of it being a different kind of self-talk, because I think if that would have even been a bigger trigger for us,
right?
that there was something going on there. I mean, there had always been that, she just had her own little world sometimes, and she would talk to, and you would say, "Who are you talking to?" And she would just say, "I'm just talking to myself." And it's like, okay, well, that's fine. Or she's talking and sort of doing a scene from a movie that she saw, because she's sort of processing it and remembering it. So there was nothing at that early stage that was concerning to us, other than it was so extreme that we felt like she was slipping away from us even being able to engage with her. And see, around that time, she had been doing this weather show on Facebook for 3 years. This was a homeschool project because she liked the weather. She wanted to do videos, and it just sort of morphed into this weather show. And I remember that it was July 10th last year that we said, okay, we can't do this anymore. She was still willing, but we knew that there was something wrong, and she was starting to lose her voice. She was becoming hoarse. And that, now that I've had the opportunity to talk to many families whose loved ones have experienced regression, that is so common, that selective mutism. So that was sort of the next thing that happened, where we were like, oh my goodness, like what's going on here? At the time, we thought that, we thought it was a thyroid issue, right? We thought that's okay. It'll be a pill that'll fix it, because it looked like she had muscle weakness. We know now, because as it progressed, it wasn't, because she wouldn't touch the car door. She wouldn't pump the soap pump in the bathroom. She wouldn't, turn the taps on. We thought that she was feeling like she was too weak to do it. So again, we thought it ticked the boxes for some thyroid issues, and went and had blood work done. We know now that was it was OCD. And, it wasn't that she couldn't open the car door. It was that she didn't want to touch the car door, as an example.
But you know what, to be fair to you and the experience that you've had, doctors would assume the same thing first, right?
Sure.
They would also look at thyroid first. Yeah. So you're working with the best knowledge that you had at the time. It sounds like, from what you've described, that it sort of fairly quickly began to really affect her day-to-day function. Like, there were some little things in the beginning, but then you're describing not opening doors, not touching soap, a lot of self-talk and withdrawal. And that's not the Kaylee that you described initially, who was involved in the everyday and had her own TV show on Facebook, right?
Yeah.
Were there other ways? Was she still able to eat with the family? Was she withdrawn from family life?
She was withdrawing from interests. I mean, she had always been, she would spend like hours on her swing in the backyard, swinging, singing, like that was her happy place. She had no interest in going on her swing or going on the trampoline or playing with Lego. She's again, now I can look back and I can see what was happening, but she was slow moving, slow to process information. But it was really, and it did happen. I mean, that sort of happened over the course of, a month, I guess. I don't know. But then she had a full psychotic break that lasted about 48 hours. That was the end. Like, that was when, that she became pretty much bedridden for weeks after that. I mean, that was when we knew, all right, this is, we have no idea what this is. And it was the first time in my life that I have ever called a crisis hotline, right? And you're always like, you don't call crisis hotline. That we'd had nowhere to turn.
Right.
We had no idea what was going on. And that psychotic break is what took us to Emerge. And then we sort of started doing research and, found a name for it and started to get some answers.
Let's talk about some of those first steps. So you went to Emerge. We know other families who've had this experience as well, and Emerge hasn't worked out very well for them.
No, we've had moments where Kaylee has wanted to go to Emerge because she thinks it's the hospital. That's where they're going to. And
ideally,
we knew pretty quickly that there was nothing they could do there for us. It wasn't that there's anything wrong with Emerge. So the first time, again, if you've never taken your delusional psychotic child to emergency and had to be there for like 7 hours, like that's like the worst experience ever. And she hadn't slept probably in 2 or 3 days, right? The only thing that I think it helped us with, and they wanted to admit her, and I did that thing that I'm like, I think I've seen this in the movies where you sign the form saying, no, I'm taking my child home. So we did not want to admit her. We felt that would make things worse, that was not something that was going to be helpful. But it did kind of speed up us getting like an MRI done. And it's unfortunate because it's like you can usually get those things done quicker if you're admitted. There. Right. But the ER doctor we had was concerned enough that she followed up with us and she pushed a little bit to get us in for an MRI sort of within the next week. So there was that decision of, well, if we stay, we can get these tests done faster, but we just didn't want it. We didn't want to stay. And the other time where we went to Emerge, I don't know, was probably, months later, where Kaylee was in distress and she was having issues with her vision. And she was like, it's so hard. She was like begging us to take her to the hospital because I'm sure she was wondering why are they not doing anything? So we did. But again, first of all, it was obvious to them this was a complex medical situation. There were already doctors involved. There was no immediate emergency. Yeah. They checked all her vitals. That's basically the only thing that we got out of that visit. And from that point on, we had a blood pressure machine. We would just check her vitals at home, right?
Yeah. Yeah. Oh, yeah. This sounds so much like the other families that we've known in this situation. And I really hope that people who are listening to this don't have to live this experience, because there's examples of people who have lived it in this order, in this way. Because like you've said, what it takes is to have an inkling that DSRD is a possibility. And you're doing an amazing job in sharing this very hard story. And did you want to take the next sort of section?
Yeah. So kind of just moving forward, when and how did you discover that this was more than thyroid, that there's something going on, and kind of come upon the Down syndrome regression disorder?
I just Googled things. I don't even remember.
Desperate moms.
Right?
Desperate moms.
I Googled. And I reached out. I reached out actually to the and honestly, I don't remember what order. I'm sure someone in my family is better at remembering, but when you're in it, you don't remember when things happen. But I remember, and I probably have record of this, that I contacted the Canadian Down Syndrome Society and to see if they had any answers. Sadly, I didn't get anything from them other than the suggestion that of early onset Alzheimer's, which is ludicrous, but whatever. But it certainly was the first time when I went, you know what? There's not a lot of information out there about this, right? Yeah. Like what? There's no. So it was through Googling and Facebook that I found the word regression, and then found the Facebook group that Eileen started, and that was the best day ever, because it was like, oh my goodness, there are people all over the world and they understand this. It was also a little bit frightening because it was clear from those discussions that there was a lack of knowledge out there in the medical field, and that people in certain countries were fighting to get the treatment that they needed, or even to get doctors to listen to them, and that there were families, they were 10 years in on this journey, and they still were trying, we say, get their kids, get them back, right? Get them back. We all talk about getting them back, right? So that was pretty freaky. It was like, oh my goodness, I don't think I can I don't think I can handle this, but what are you going to do? Right. So, so it was really finding that regression group and getting the information that they had made available in the group from Dr. Santoro. And thankfully, oh my goodness. And again, we're the lucky ones that we have doctors. I have a family doctor who, like, I went in and said, here's what we think it is. These are the tests they say we have to do. Now, I know many doctors who would be like, well, I don't even know how to read that test when the results come back. So, or I don't know what this is, so I'm not going to do. Our doctor ordered every single test on that list. Didn't question us. Right. I think that's probably rare to have that happen. Right. So I don't know how we lucked out and got that. Well, you know what? And I think this is sort of another little piece of this. We have a really good relationship with our doctor. We have advocated for our other kids over the years. So we have that rapport with her. I think that it's almost worth developing something so that families in our situation have a mentor or an advocate, because if you go in and talk to a doctor and you don't, and I hope this doesn't sound bad, but if you're not to articulate to a certain degree, informed to a certain degree, and have that insight of how to speak to your doctor, you're not going to get anywhere with them. And that's not fair at all, but that's the reality of it. If you annoy your doctor, or if you speak and your doctor has maybe an ego and they don't like the idea that they don't know everything, they're not going to help you. They're not going to help you.
And I think you brought up such an important part, that it's unfortunate that you as a parent have to do so much of the advocating when, and you're already dealing with so much. So now you have to convince this medical professional that what your child is going through is real. And this is some of the things that we need to do to help figure out what's going on. And as our listeners will kind of find out later in the podcast, when we talk to Dr. Quinn, who you referred to a bit earlier, she said the same thing. She said, parents are going to unfortunately have to be the ones that teach the doctors in this case, because this is something that's newer on the radar, but that doesn't mean that they shouldn't listen to a parent because they know their child best. So I think your story is going to hopefully help a lot of other families being like, you know what, I'm going to go in with this list. I'm going to go in and tell them what tests need to be done. Because
And for everybody listening, we're going to provide the list. We have the list. We'll put it on the episode. And we're going to provide the list.
As a parent, I'm way more committed to doing the research on this than a doctor is. Right? Yeah. And I try to respect that. Like we were, our GP hooked us up with a pediatrician. I mean, which that was a blessing. Kaylee's 17. She'd never been to this pediatrician. He agreed to come on board and help us. I can't remember what I was going to say with that. Sorry.
That's okay.
Just
about advocating.
Something about advocating. Oh, but that package, like I learned early on to like how much stuff have I printed on my computer, right? To figure out what publications, which list, put it in a nice envelope, bring it to the doctor. And now I can tell parents, these are the things I want you to bring. This is what you should say. And the number one thing that helped us get the treatment that we wanted, and we're still fighting to get more pictures, a collage, pictures of Kaylee before she got ill. Because you go into that doctor's office, even if they're a doctor that works with developmental disabilities, all they see is what's in front of them. They need to know where you started and what you're fighting for.
Absolutely. Yeah. They need to know exactly. Yeah. Pictures, videos, just anything that can show them what was before and what we need to get back to. So that's very, very important. And I also really appreciate you mentioning that not every person is capable of advocating like that, right? Like not everybody has access to that, or the articulation, or the, like a lot of people are more reserved and they're not the outspoken kind. So it is hard, and it is, those are the parents also that need advocates as well and need support and mentors. Yeah.
I'd like to point out too that the other thing that we found challenging, and again, we're not in a big center, right? Like Thunder Bay is not huge. We have a great hospital, but I don't, if you go to the States, every state probably has a clinic specifically for patients with Down syndrome, not just pediatrics, but probably right through, to adulthood. So the team that we have for Kaylee is a team that we had to create, right? So we have to do the work to keep them each informed and do what we can, even if it's a little phone call. I mean, I send so many email messages and updates, and I make logs, and I do all of that work to keep them so that they feel like they're part of this team, because that's what I need. It's not like, oh yeah, I want them to be a team. I need them to feel like a team so they can work together to get Kaylee well again.
Absolutely. So now that you kind of had a name to this, and you discovered the Facebook group that Dr. Quinn started, what are some of the treatments and strategies that you kind of started to employ with Kaylee to kind of help her recover?
When we started, because we were trying to get in to see a dual diagnosis psychiatrist who could give us some guidance on treating the symptoms, because her symptoms, fairly common in regression, were psychosis, like delusions, OCD, catatonia. Horrible things to witness in your child. So we needed to give her some relief from that. But our family physician, and hats off to her, was honest enough to say, okay, I'm a little out of my element here. So we started with a low dose antipsychotic, right? Let's try to give her some relief, and a low dose of Ativan at the time, which we were giving as a sedative. Let's just try to give her some calm in her life. It wasn't really until we began to see the dual diagnosis psychiatrist, who again, I don't know, we're lucky. She has a son with Down syndrome. And the day she told me that in her office, like seriously, I was like, okay, now I'm going to cry. Right. Yeah. I was like, this is meant perfect. To be. Yes. Yeah. So she was able to give us guidance on, okay, what are the medications we need? So antipsychotics right now are the number one thing in our life for treating Kaylee's symptoms, because we want at all costs to avoid another psychotic break. She's had at least two. I'm worried, like, can that sweet little brain of hers even handle another one? And living with psychosis, like, we have kept her on Ativan, but now it's used to treat or give her some relief from catatonia. And that's something where, like, seriously, I used to think, your catatonic was like you lift your arm up and it stays there. I had no idea really what being catatonic involved, and the list is pretty long. And all of these things sort of meld together, because you're like, is that the catatonia? Is she doing that because of this? Is that a delusion? So antipsychotics, we did have her, or do have her, on an SNRI. Again, that was before we started seeing the psychiatrist, because we were just getting medication. Although we consulted with the manager at the mental health clinic, we were walking a fine line, and that psychosis was there. And we were like, okay, if we're still waiting, what else can we give her? So we put her on an SNRI, which actually now we're in the process of taking her off of that. So when we began to see, then it's like the whole thing about underlying cause. We were, again, lucky in that Kaylee's blood work showed high strep antibodies. Like her strep titers were like in the 600s, and I think normal is like 200. Right now, because of that, whatever your doctor's opinion is on PANS or PANDAS, whatever, that allowed us to get her on antibiotics, right?
Yeah.
There's no infection in her body, but obviously she was still producing antibodies. So I think it's just the inflammatory, it's treating inflammation. So we got, antipsychotics, Ativan, antibiotics. Those were the things we were on initially while we're still trying to figure out what treatment, like we're not even, it's like
those are symptom based.
Yeah. And you're like, we're not even treating the underlying cause yet.
Yeah,
so we worked for a very long time. We added another antipsychotic. We tweaked that. I mean, I had no appreciation really on psychiatric medications and what that process is for. It's like you go low and slow. So it's like, you are so desperately wanting to treat that symptom in your child, but it's going to take weeks and weeks
to get therapeutic,
to get to that stage that you want to get at.
Yeah.
So I had no clue. So I think it's understanding that it's okay, and you got to treat the symptoms because you can't function even day to day with your child in that state.
Yeah.
You have to find that. And that's okay. And then in the meantime, you're researching and trying to figure out treatments, which we've started. We've had one round of IVIG, immunoglobulin treatments, and are waiting to discuss having more. And we have a referral for ECT, which is the thing that you get kind of scared when you hear about ECT, but it's proven highly effective, specifically for catatonia. So we're waiting to go to talk to the chief of psychiatry here in Thunder Bay to get the ball rolling on that. And those would be the main treatments.
Yeah. Because I think it's important that you mentioned that, until you really find the underlying cause of what's happening, you still need your child to be comfortable and to be able to function. So you have to treat some of the symptoms first. So, because of course, even the term antipsychotics can scare some parents and they're like, oh, I don't know if I want psychiatric medication, but if it's helping your child just be able to be at baseline and be able to function, that it is something to consider until you can really figure out what the root cause is and do some more of those treatments.
Yeah. I mean, nobody wants to have their child on antipsychotics.
Yeah,
nobody
exactly.
wants, as an adult, you don't want anybody, right? But when your sweet child is having a psychotic break and is hearing voices and is delusional, you're like, bring me the antipsychotics, please. Yeah. And it's like, I will get her off them later, but right now we need them.
Calm.
Yeah.
Right.
Yeah. Calm. Yeah. Exactly. Yeah. So it's been just over a year now since this happened. How is Kaylee doing currently?
Well, it's funny you said the bit about baseline, and that made me want to say, and again, because we had a virtual appointment with our psychiatrist yesterday morning, and she always says, "How are you? And how are things going?" And I say, "Good," but don't confuse that with us being complacent. We are nowhere near baseline, and we are nowhere near we're not stopping yet. So we're good, meaning everybody's alive in the house, and we all ate some food today, and we're doing good. So we're doing good, but with that little thing to add,
for sure.
Again, and it's probably a combination of things. It's probably a combination of we've got the antipsychotics where they should be. They're not perfect. Kaylee still has what we've called, because we don't know the name for it, like breakthrough psychosis almost daily, where she still hears voices or she still has sort of delusional thoughts. The difference now is it's sort of malleable, like she can tell us when she's hearing voices. We've been able to work with her to help give her tools so that she knows, when you hear the voices, you don't have to listen to them. You can tell us that you're hearing voices. If I need to give you an immediate release Seroquel to kind of quiet them for a while, we can talk her through, because she still has catatonia, so we can talk her through. She gets stuck. So she gets physically stuck. And she'll be like going up the stairs, and you can see she's been in the same spot for like a minute or two. And we can say, "Are you stuck?" And she'll say yes. So we can go up and physically help her move, but we're also giving her the tools to like take a few deep breaths, focus on what, we're making it all up as we go. Also,
it sounds like
this is just, we're making it up.
It sounds like the difference is though now she can attend to you.
Yeah.
Right.
Yeah.
She can be with you in the moment so that you can help her better because she can explain a little bit more what the problem is in the moment.
Yeah. And that's a challenge, really, if you think about it, on top of all the other challenges as you're dealing with loved ones, with various intellectual challenges and the abstract nature of psychosis, for example. It's so difficult because even the voices, you're hearing voices. They're not real, but but she's hearing them, so they are real. And you don't want her to not listen to her own voice, but how do you even explain that?
Yeah.
Right. So it's hard,
complicated.
It's hard and complicated. Yes.
Yeah. An abstract nature, and then being able to communicate how she's feeling too. Right. So it's good to hear that she's, like Marla says, she's at that point where you can, I don't know if rationalize is the correct term, but you're able to communicate and kind of get at her level and see what she needs. And she's able to communicate some of her needs and how she's experiencing her world. Right. So that's,
and I can't imagine, imagine the challenge if your child is nonverbal, right? It's got to be so hard.
It's another,
so hard.
Yeah. You're doing such amazing work. And thank you so much for sharing your story with us. I know families that will hear this will find so much solace in knowing, that there is another parent out there that's going through this and learning from you. What advice do you have for families who are currently going through this with their loved one?
Well, one that there's hope, right? Like, like a year ago, I had no clue that we would ever get to the point that we are now. Even 3-4 months ago, I can tell you that my son was planning on getting married in the United States. And we thought we're going to miss his wedding because Kaylee, she wasn't stable. It was after her first round of IVIG, where sometimes there's a decline and she got worse before she started to get better. And we didn't think we could even make that road trip. So, but you work with your doctors and you talk to them every day and you tweak things and so there's hope. The best advice, and this wasn't my advice, this was from the group, was it's a marathon, not a sprint. And I remind myself of that all the time, that you're not going to get it all done today or even this week. It's okay to take a day and say, I can't read another medical paper. I need to just check out and get through today, and I'll figure the rest out another day. And it's the one time, and it's hard because I know that not everybody has this sort of this circle of friends around them. And we're a family who we just don't ask for help. We'll figure it out. But this time, oh my goodness, those first 6 months, we've eaten a lot of lasagna. That seems to be the food that people like to bring you.
Very freezable.
Yeah,
Very
that's
freezable.
probably what it is, right? Yeah. So if people didn't bring us food, for that, I don't know what we would have done. So people bringing us food, gift cards, Tim Horton, whatever, right? It was huge. So you have to ask for help. You have to accept the help. In order to survive it. Yeah.
Important. You have to expand your village of people, right? So just so that you can rely on them as well.
And I think recognize, I've probably not even shared to whatever degree I could the horror that this diagnosis has been. I don't want to sugarcoat it at all, because honestly, and we're a family that's faced challenges. We are not wimps. This is the hardest year we have ever had to live through.
Yeah.
So recognize that, this that it's hard. It's very difficult.
And I also want to point out, and people will see in the second part of this episode where we talk to a couple of doctors about this, that you're not alone in pushing to understand this better. There are not very many doctors who understand what's happening here, but there are a few, and my goodness, are they pushing? Mm-hmm. They want answers too. And this is one of those areas that I am hopeful that we will continue to know more and more about, as stories like yours become more well known, so people know that this is happening. I think it's very important.
Absolutely. Cindy, before we kind of end for today, are there any resources or anything that you found really helpful that you would like to share, and we can include links or anything for our listeners?
The Down syndrome group was sort of where I found a lot of information. Now, not the restriction. The group itself is designed for people who are caring for a loved one with regression. And that's not meant to, not include everybody, but we share a lot of personal stuff, very raw moments on that page. I can tell you that the plan is to have a public group page or public page as opposed to a group, where some of the files and publications from that group will be shared and made available, so that people who aren't sure if it's regression, think maybe it is, or are just curious, they'll have a place to get information. There's the Down syndrome special interest group in the States, and Eileen, Dr. Quinn will probably have more resources that she can share as to sort of where people can go for information. But our goal, those of us in that group are like, okay, we're kind of in the start of this, right? The consensus paper just came out. Things are just starting, which is great. I mean, part of me, it's like I love-hate thing. It's like, it's very exciting and it's very interesting. I wish it wasn't my child, but that's where we're at, right? Yeah. So we want to, the parents in that group, we want to do what we can to make sure that when somebody sits down at 2 a.m. and Googles, that there's a place where there's easy access, concise information to at least get them started. I would love to see, we need one of these special interest groups in Canada. Like I think that we need to do more in Canada, the medical community all around, not just regression, but all around, to do more for individuals with Down syndrome, because the only sort of clinics that I'm aware of are, again, they focus on pediatrics and they're within hospitals. And I'm like, why aren't we doing more to encourage doctors, for example, or medical students to specialize in Down syndrome? I don't know everything. I've not Googled everything, but I'm not even aware of any doctors in Canada who would say that they specialize in Down syndrome. And I bet you there are some in the US and the UK. So I'm like, we can do better. We can do more. Right?
Absolutely. Well, we really want to thank you so much for joining us today and discussing, it's a hard conversation to have, but we know that it's going to help so many of our families that are listening, and hopefully the professionals that are listening out there will be galvanized and wanting to go into this area of research and really help advocate for our families. So we really appreciate your time.
I'm happy to do it. I hope that it helped even a little bit. And I didn't cry.
Well, thank you so much, Cindy. We really appreciate it.
My pleasure.
Okay. We are delighted to bring you 2 amazing guests today who are essentially celebrities around our office. We don't often, have breaking news in Down syndrome that causes such a stir, but these 2 amazing physicians caused just that. So today we are joined by Dr. Jonathan Santoro and Dr. Eileen Quinn. Dr. Santoro is a pediatric neurologist with special training in inflammatory and demyelinating disorders of the brain, spinal cord, and peripheral nervous system. His clinical research is in Down syndrome and the association between autoimmunity and the development of cerebrovascular disease.
Dr. Quinn grew up outside of Detroit in a family of 7 kids. Her younger brother, Danny, had Down syndrome and had a big influence on her choice of careers. She attended the University of Michigan for undergraduate and medical school, then moved to the University of Rochester for her pediatric residency and fellowship in developmental and behavioral pediatrics. She has been a developmental pediatrician, oh, we love those, at the University of Toledo College of Medicine and Life Sciences for over 30 years. She has 4 wonderful daughters, the youngest of whom, Sarah, is 24 years old and has Down syndrome. Welcome to the podcast, Dr. Santoro and Dr. Quinn. I'm so excited to have you on.
Thank you for having us.
Thank you.
Yeah. All right. So in the grand tradition of the LowDOWN, we always like to start off the podcast with 5 secret questions just to kind of get to know you a little bit better. So I'll start them off and then I'll have Marla take over. Okay. So Dr. Santoro, let's start with you first. What's a crazy but true fact about you?
Crazy but true fact. I think the one that I like to brag about the most was I gave a speech that opened for the Dalai Lama when I graduated medical school. And people often don't believe it, but I think there's even a YouTube video of it online. So that's my kind of crazy story.
Whoa.
So we met and he's like a totally normal guy.
I mean, that is wild.
That's wild. What was your speech about? Like, what was like the theme or the topic about it?
You know, it was, I was graduating after spending almost a decade in New Orleans. And so It was about, Katrina and how the city had recovered and how all of that was part of the educational experience for all the graduates. So it was a very cathartic talk. And it was, I can't say I was better than the Dalai Lama, but I think it was a pretty good talk at the end of the day.
That's super awesome. Dr. Quinn, what about you? A crazy but true fact?
Well, I don't have a YouTube video of this. And by the way, John, I am going to have to look up that YouTube video. Very interested. But a kind of crazy thing. I worked my way through college and med school with a variety of jobs. But for a couple of summers, I worked in a bakery where one of my jobs was, it was kind of an industrial bakery. So it was, one of my jobs was to try and put the icing on cakes very fast as they came down a conveyor belt. So that was a very interesting job. And you have to learn under pressure under those situations. So,
oh my goodness. Yes. And you did that through residency?
No, just through
I was going to say, so you never slept ever?
No. No, residency is 2.5 jobs by itself. So through college and
wow.
It's funny when you said that, I was picturing the scene from like I Love Lucy where Lucy and Ethel are trying to.
It was exactly the scene from I Love Lucy. It was hilarious. And, I was just summer help filling in for people on vacation who did this all the time, every day. So it was,
oh my gosh, awesome.
it was fun. I wish I did have a tape of it. It would be very interesting to watch.
We need to recreate that experience now. Okay, this is a really funny question to get to after Jonathan talked about the Dalai Lama. But what is the most appropriate thing to put on toast?
It's a very personal question.
Very personal question. Dr. Quinn, why don't we start with you first on this one?
It's got to be butter. Just butter, not margarine.
Yeah, I know.
Real butter. That's my favorite.
Fantastic.
I am way too boring. I'm going to say nothing. I mean, I drink my coffee black. I like my toast bland. I mean, I think I'm just that kind of guy.
Just plain bread. Oh, man.
Nothing wrong with that, for sure.
Oh, that's so funny.
All right, Marla, go for it.
Sure thing. So the next question is, what do you do to get yourself to get through an activity that you really rather avoid? Dr. Quinn, let's start with you. Do you have any tricks to get through something that you really dislike doing?
I just focus on when it's going to be done.
There you go.
There you go. Have to live through this, and then at the end, life will be better.
Yeah.
Excellent. And Dr. Santoro?
This happens all the time in research and writing. And what I do is I wake up extra early and I just do it. And I find that if I can just start the process before my brain is actually awake, I'll just trick myself into actually completing the task. So that's my little secret.
Yeah.
Don't tell my kids, they'll wake up even earlier.
Seriously. Oh boy. Okay. Next question is, what's your favorite hour in the day? Dr. Santoro, let's start with you.
Early morning when I can actually get stuff done. So I think
Are we talking
I've always
4s, 5s, or 6s?
Yeah, 4s and 5s. I think I've always been an early riser. And some of that was because my family's on the East Coast and I live on the West Coast now. So I would wake up when I was in residency and I would call my grandmother at 4:30 in the morning, she was just waking up at that time. So we'd have like a half-hour chat every day when I would drive into the hospital. So it's always that early morning piece has just been important for me for family connections, for writing, for doing a lot of work. So.
Mm-hmm. And Dr. Quinn, what about you?
Well, I would have to say the opposite. I love 11 p.m. when I am alone. Everyone else is in bed. There's no distractions, and I can just focus on the task at hand. I am a night owl as opposed to an early riser, which makes it convenient with communicating with John because we're on different coasts and time zones. And I know when I sit down at 11, he's still checking emails and things like that at 8 p.m. at night. So it's been convenient for that.
Totally. And this last one, we asked our connections at Mass General this question, and they had very strong opinions. So we thought we'd ask you too. And that is, what is your favorite writing utensil? Some people don't have strong opinions, but some people really, really do. Hint is one of those. Dr. Quinn, do you have a strong preference on things to write with?
I do not have a strong preference. I think I just like pens, though. Mm-hmm. Pens. I'm left-handed, and that's one of the traumatic experiences for lefties is when they start in school and you start with pencils. As an OT, you'll appreciate this.
Smudgeroonie. I'm left-handed too.
You smudge it along. So pens are less smudgy. That's
pens
my
that dry fast. That's a must.
Yes.
Yeah. Mm-hmm.
I had to open my desk drawer to figure out what my answer was. It's the Pilot G2 0.38 millimeter. It's very specific.
Very specific pens. Exactly.
Oh,
with the amount of writing you guys do, if the pen's no good, then it's like, yeah.
All right. Well, thank you for indulging us in those questions. Hopefully our listeners feel like you are full people and not just your brains that apply to research. I think that's important. I do want to say a little chunk before we get into our topic. So before we talk about regression, I want to make the purpose very clear to our listeners. And our purpose in this episode is to reduce the isolation that families have when their loved one is experiencing regression. And beyond that, we're hoping to provide some hard to find information and resources and kind of make those a little bit more easily available so that families can feel informed about what's happening. If the topic of regression doesn't apply to you as a listener right now, and you're already stressed just listening this far, then I think you should give this episode a pass. It's never our purpose to cause undue stress to families. So use your judgment. And if it's stressing you out, skip. That being said, let's start into it. Can we start by talking about what is regression so that everyone's on the same page getting going? Dr. Quinn, can you start us off with that?
Sure. Regression is just a loss of previously acquired skills. So there's a number of different areas that people can have regression in. It can be in things like activities of daily living, people's ability to take care of themselves and wash and dress and that sort of thing. You can also have regression in language and communication, or in motor skills, in memory, regression in behavior. So there's a number of different areas you can have regression in, but it just refers to loss of a previously acquired skill level.
Mm-hmm. And Dr. Santoro, let's talk just before we get into the specifics. Is regression inevitable in Down syndrome? Does everybody go through regression?
Not necessarily. So, I think an important piece of when we're looking at regression is when is it happening? So early in life, single digits ages and early childhood, we often think of regression being associated with autism spectrum disorders. Whereas later on, where, this is the regression we'll be focusing on today, there seems to be this regressive phenomenon in early teens. In females, it seems to be right around the puberty time. In our male patients, it tends to be a little bit later, where all of a sudden we're seeing that these patients are regressing. And so the term autistic regression has been used in that population for a long time, but we know, that autism just doesn't suddenly develop in the teen years. And then other types of regression on the other age spectrum are more related to Alzheimer's disease. So all of us regress, whether we want to, believe it or not, whether we have Down syndrome or we don't. But I think that when we're really talking about regression, we're talking about this more subacute, out of nowhere kind of surprise type of phenomenon. But as we'll talk about later, a lot of it is, is there another explanation for this regression or is it something organic?
When should a parent wonder if regression is happening? So I can paint a little bit of a picture here. Let's say somebody, had a cold for a few days and then their behavior is kind of off and maybe they're not as chatty as they were before. Do we need a full scale panic on that? Or, at what point are we talking about regression that we need to really worry about?
Well, that's a good question because with any child, they can have good days and bad days. And you think that they're on a good path and then suddenly they forget all the words that they used to be able to read. And so that kind of ebbing and flowing is pretty normal. But I think the time to really be concerned is when there's a substantial change and that it doesn't get better in a week or two. And in fact, you start losing more skills. In my mind, that's when I would say as a parent that we need to be more concerned. If it really starts to affect their daily life and interfere with their ability to do the things that they used to do.
Okay. And I think many parents know what their kid looks like when they get sick, right? So this is something where, I tell a lot of families, if your mom and dad radar is going off, that's the time you should be contacting your doctor. And there's no set, 10 days, 7 days, right. Everything can look a little bit different, but with regression, as we're talking about it, when something's off. It's those activities of daily living that just are evaporating before your eyes.
The next thing I want to do is do some sort of piecing apart of the different types of regression so that we can get into our topic today with a lot of clarity so that we're not muddying the waters for families who are listening. Can we talk about sort of the most common causes of regression in early childhood? Dr. Santoro, you touched on it. We're talking about differentiating an ASD type regression from others.
Yeah, and I think that this has historically been something that in the early childhood years, we know that comorbid autism spectrum disorder and Down syndrome exist to the tune of between 20 and 30% of all persons with Down syndrome. But that diagnosis is usually more slow. There can be regression of skills, but it doesn't come out of the blue. And I think that when we're looking at these temporal, associations, it's that there's this kind of slow decline, over a period of time. There are some patients that can be a little bit faster, but I think the challenge with young children is that there's not a biomarker for autism. And, we can get an MRI and it is usually negative. And we can do the psychometric testing, which says it indicates autism, but it could indicate many other things. And I think that this is something that we've always struggled with. But I think that time frame is really helpful for delineating both in terms of the age of onset and the time it takes to actually have that process occur. But, Dr. Quinn can also, go into this. She sees a lot more ASD than I do, certainly in my practice.
I think certainly the age. Typically, we know that autism prevalence is higher in young children with Down syndrome than in those without. So we need to have our awareness up about those sort of symptoms that may develop. But it is really looking at so as John mentioned, it would be very common to start developing autism symptoms when you're 10 or 12. It would really be in the younger age group. Now, we do know that autism is diagnosed later in children with Down syndrome, but that's because it's just a more difficult. I always say that's one of the most difficult things that I do is diagnose autism in a young child with Down syndrome. And I know that you've had speakers in the past talk about the dual diagnosis, who did a wonderful job. But it's difficult because we're looking for atypical development in the context of already atypical development. So it can be a little bit trickier to sort out what is typical behavior for many young children with Down syndrome. For instance, we know certainly communication can be delayed. Verbal words can be more difficult for children with Down syndrome to start using, but that intent to communicate is usually still there. So young children with Down syndrome they may not have the words yet, but they use everything at their disposal to pull people in and get their attention and to do that back and forth communication. They use facial expressions and gestures and smiling and eye contact, and so there is a difference when you're looking at it. And also, young children with Down syndrome often will have some repetitive behaviors. But I think it's that what I look for in diagnosing autism is that social piece. That is usually, though they might have delays in other area, their social emotional connection is spot on. And in fact, one of the most endearing qualities I think of people with Down syndrome is they tend to be able to, and other families will bear this out. I call it a special magic of Down syndrome, where they tend to attract people to them. I know it's their personality and that social emotional connection. So yes, it is a difficult diagnosis to make, but I think as we've been talking, I think the age is a key thing to look at there. Right. This, even though. So sometimes the diagnosis isn't made till later because people have trouble separating out what's Down syndrome and what is autism. But if you ask parents, oftentimes the symptoms have been there. They just weren't recognized for what they are.
And that's where, the field of medicine has changed and progressed too. So depending on who was doing your assessment and when and in what sort of decade, the thoughts on that have changed drastically. So I do have some older students who didn't get a diagnosis when they were little, despite clearly having a dual diagnosis on board, just because whoever they worked with wasn't aware that was even a possibility. And that's really changing, certainly with the AAP guidelines and some of those more up-to-date documentation.
I have patients who, families who say when their child was young, they were told that people with Down syndrome couldn't have autism. So
that was a collective eye roll for everyone listening. Everyone was just like, but yeah, we've all come up against that for sure. And then as we move towards sort of tween, teen, age 10 plus, 10 to 20, this is when we're not expecting to see, autism symptomology come online or come on board. So if you're seeing a regression or a skill loss in this age group, it typically means something different. So let's get into it. I don't know which one of you would like to start.
Well, I guess I'd like to say, because we definitely want to deal with this topic of the Down syndrome regression disorder, but there are many areas people with Down syndrome can have regression, and also milder degrees. So I think it's important for families to be aware of the different medical conditions that can happen in people with Down syndrome. And that can cause more milder types of regression. So I think it's important if people start to see a change in their child's behavior or in their ability to do things, is to make sure that they are up to date on all the screening recommendations, and that they have a physician that is aware of what other things that might be happening. So we know that things like hypothyroidism and sleep apnea and atlantoaxial instability and all sorts of medical conditions that people with Down syndrome are predisposed to can cause changes. Sometimes there are people with Down syndrome, even though they're verbal, they have difficulty expressing what's going on, and they might have difficulty locating sources of pain or discomfort. And they instead of talking about it and telling people about it, you'll notice a change in their behavior or their skill level. So I think it's important to keep that in mind also, that sometimes when you start to see a change in your child, to make sure that, has he had a screen for the thyroid? Is he having symptoms of, say, celiac disease? Is he up to date on his vision and hearing screens? And to make sure that some of those aren't feeding into this type of change in behavior.
I'm so glad you brought that up. And Hannah and I speak about this regularly. The communication of pain is very, very hard for people with Down syndrome. And we often see behavioral things instead. I've said this in other episodes as well. We see more hiding, acting out, an increase in behavioral things. And it can be even, what we would maybe consider to be less grave things like constipation that can cause a real behavioral change. So medical workup first, and then if that gives you nothing, and all those things are clear, then we start looking at other things. Dr. Santoro, do you want to start us off on that?
Certainly. And, I think that it's interesting is that, when we're talking about regression or Down syndrome regression disorder, DSRD, it's really a diagnosis of exclusion.
Mm-hmm.
Like our workup is not to diagnose DSRD. Our workup is to rule out other explanations for it. What are the common things in persons with Down syndrome? A lot of that is borrowed from existing literature on things that we know that can mimic this, right?
Mm-hmm.
So once, we've actually ruled all of that out, the features that we look for are kind of put into three different categories. With any diagnostic criteria, we always say you have to exclude all the other things, right? So that's kind of already what Dr. Quinn was mentioning. The second thing that seems very unique about DSRD is the symptom onset tends to be pretty quick. So we go from high function to, oh boy, what's going on? Why can't you toilet independently? Why can't you, do all of these other tasks that you've been able to do? Generally over a few weeks. In our new consensus criteria that was just released last month, we kind of used a 12-week guideline to say that this regression should be occurring relatively rapidly. It's not that slow decline that we see in Alzheimer's disease or an autism spectrum disorder. And then really there's 8 core features that we look at. The first is an altered mental status or a behavioral dysregulation. So that can be things like confusion. It could be inappropriate laughter. Sometimes it can be changes in eating behavior. So everything from anorexia and not wanting to eat and losing quite a bit of weight to hyperphagia, just nonstop eating, mom and dad have to lock the fridge type of thing. The other thing that we see is a cognitive decline. That can be things like apathy or just not willing to engage with family members, with loved ones. A lot of patients will just kind of sit in their room and not leave or not do anything in the early stages of the condition. And then often there can be either a memory impairment or more of this slowed processing speed where you'll ask a question and you can tell the gears are turning, but there's really just not a response ultimately. And then from there, we also see that as Dr. Quinn was mentioning, that social piece. So there's social withdrawal, there's inability to perform the activities of daily living, there's a rigidity around routine. So leaving the room will provoke a tantrum, aggression, things of that nature, decrease eye contact. And then again, coinciding with this apathy, they're not enjoying things. We've had many families say that they're just kind of cruising through the motions during the day, which is hard because so many of our young persons with Down syndrome are very animated, loving life individuals. So this is often the most dramatic change that brings people in for care. Obviously, if there's any focal neurologic issues, so that would be weakness, sensory changes, or a seizure, you gotta take the express lane to get evaluated. And then the other kind of 3 components that we see quite a bit are insomnia and circadian rhythm disruption. Insomnia, interestingly, is often very early in the disease process. People will just stop sleeping or be 2 hours at night. Then we'll start to see some of the language deficits that can be whispered speech at first, then a decreased verbal output. And then in many situations, it will go on to full mutism and not being able to communicate at all. Yeah. And interestingly, that crosses domain. So that's both your expressive language and your ability to point and gesture or sign for many of our patients that don't have as advanced expressive language function. And then I think that the 2 things that often are, for me in neuroimmunology, we see a lot of psychiatric symptoms. So we'll see anxiety, depression, a lot of OCD. And not OCD, you got to touch the doorknob 50 times before you leave the house or that hyper cleanliness, but it's really about rigidity and having thoughts that are just trapped in this circuit. And often there's this fixation. Sometimes it'll be on a Disney movie or a particular show that they like, but it's almost like because it's such a repetitive loop, they're almost in that other world as opposed to in the world that they're actively surrounded in. Yes. And then the last thing that we see is the presence of a movement disorder. Often this will be catatonia in about 3/4 of our patients. And then we'll also see bradykinesia or slowed movement. It almost looks like somebody has Parkinsonism. Well, they'll just kind of shuffle along the hallway floor. We'll see freezing behavior. So you'll ask somebody to take a turn and all of a sudden they kind of clam up and they can't actually initiate that. So, that's a lot of symptoms, but if you're seeing really more than 2 or 3 of them, that's an indication that we got to get, your child in for evaluation.
Oh, yeah, that's quite the list. That's a hard list for families who are experiencing that. And we've seen it multiple times here. And it's very, very scary for families who are going through that.
I think it is a long list. But in my experience, my daughter Sarah had a full-blown regression 11 years ago. And it was certainly our experience, and speaking with other families, the sum total of all those symptoms is that your child is gone. The child that you knew, as I say, who was the light of my life and made me laugh out loud every day, is just totally different. I mean, it was like, I even say, it was like Sarah died and I didn't have time to mourn her because I had this belligerent stranger in my midst that I had to deal with. So it's really a very catastrophic thing to happen to families. Very, very difficult.
Hannah, do you want to take the next one?
Yeah. We're just processing all that too. Dr. Santoro, you were just talking a little bit about some of the symptoms of DSRD or Down syndrome regression disorder. And one of the things you mentioned was cognitive decline. So we're wondering, for a lot of our loved ones with Down syndrome, they may not have a large repertoire of self-care skills for whatever reason at baseline. So they may not be able to do, they're already not independent in toileting, feeding. And if they're nonverbal, which happens as well, how do we measure the cognitive decline in that situation?
The short answer is we measure it poorly. Right. So I think that when we have historically looked at our patients, at least at CHLA, we've found that there's a lot of high functioning individuals that come in and get the diagnosis of regression. It is very, very challenging as we go down the capabilities spectrum to make those differentiations. I think one of the keys with our individuals who may not be independent of some of those routines is to really get as nitty gritty as we can. So it may be that, your child may not have been able to toilet independently, but could indicate that they wanted to do that. And so if that's gone, that may be the piece that we have to substitute here. But I think that this is a challenge, not just in Down syndrome, but really any disorder that has intellectual disability as part of it, is that people with lower functional status don't often get the diagnoses that they need. There's, as Marla was talking about, pain in individuals who don't have expressive language is really hard to figure out. And this is where those nuances, and, I'll say it again, that the mom and dad radar of knowing this is not my child is something that you really need to communicate to your physician, because looking in a room, and I think that, we've heard this from hundreds of patients across the country. My doctors just said that this was normal for persons with Down syndrome, that there really wasn't a regression. And if the parents are saying, no, look, my child is different, and here's why, going in and actually being prepared to explain what that difference is, even if it may seem minor to somebody who's saying, well, okay, well, they weren't able to do that anyway. These are really important factors, and take a lot of that advocacy component for families to really push to kind of get that evaluation done.
Have you found that videos are helpful?
They're very helpful.
As a point of contrast.
Even pictures. And I really advise families to really do the nitty-gritty work before you go in to see the healthcare provider. So I advise them to write down exactly what level their child was at before, and then what changes that they've had now. Because I think that can be, it's easy for some healthcare providers, if they have a certain a stereotyped idea of what a person with Down syndrome is like, that they may see your child and just think, well, what are you concerned about? This is just Down syndrome. So it's very important to take the time and paint that picture of what your child was like before, and then what you're seeing now, and how this isn't usual behavior for them. And I also say for families to make sure that you tell the healthcare provider what impact this is having on you and on the whole family, just so it's not so easy for them to be dismissive. But I think videos are just that's incredibly important if you have access to those of what their functioning was like pre-regression and what they're seeing in the office now.
Videos, photos, drawings, handwriting samples, all of that is very, very helpful. Bringing a sibling, I think, has also been very helpful. And I think that this comes, and I hate this terminology, crazy mom, the mom that comes in and says, these are all the things that are wrong. And you need to, you need to evaluate them for X, Y, Z, right? We've heard it from thousands of other physicians, providers, everybody. When you bring in another person and a sibling who doesn't have kind of that repertoire to come in with the binder full of issues, that is really striking when a sibling says, I don't know what's going on with my sister, but she can't do any of these things. And it's really, that's the point for me, or when we first started evaluating these individuals with regression, that was really powerful. Of course, the videos, the photos, as all of the other things that we were talking about were really helpful, but siblings telling me that their brother or sister was a ghost. They were just in the house and they couldn't do anything anymore. That was like, oh my God, something is really, really wrong here.
And everyone sees it, right?
Everyone sees it, because I think it's so important to, if we're going to take a holistic approach, that is part of it, right? You're looking at that person from different angles because their relationship with their sibling is different. Their relationship with their friends is different. And you do different things. So then you're really getting a bigger picture of, okay, what exactly is going on and how much have they really lost in terms of their skill level. That's such a great suggestion. Before we kind of get into the actual process of diagnosing Down syndrome regression disorder, I just wanted to talk a little bit about the prevalence. The first question I wanted to ask was, you talked a little bit about early childhood regression due to ASD. If somebody has a diagnosis of autism, does it make it more likely that DSRD could happen? Is there any connection, or is it just coincidence?
I wish I could tell you. This is still the Wild West. I think that historically, I think a lot of individuals with regression didn't get the name. It was just said that this was early onset Alzheimer's, that this was just part of Down syndrome. So now that we've kind of come up with formal terminology, that we've developed an assessment tool to help physicians kind of go through the process of working this up, I think we're finding people are coming out of the woodwork where they've had the symptoms for a long time and they just didn't know what it was. Very similar to kind of what happened with autism in the early 2000s. Once we finally had a name for that condition, the rates of autism went up, so to speak. But in reality,
did we hear about it?
It was reality that we were just now able to actually capture these. I don't know. I think that it's still rare, but we really don't know how many patients are out there with this.
Well, I wouldn't be surprised if it is more likely to happen with the dual diagnosis, because we know that in people without Down syndrome with autism also have these regression periods. And so the whole catatonic picture is very common in people with autism and not often recognized. And again, it's the idea that it's difficult to recognize something atypical happening in someone who already has atypical development. But I do worry that many times in people with a dual diagnosis or in people who are less capable at a baseline, that this diagnosis is being missed. I mean, the people who have children who are quite verbal and functioning well and independent and have some academic skills, when they suffer this type of regression, all the alarms go off. But I'm very concerned about the people that may not have those skills at a baseline, but still suffer quite a bit from this this disorder, but are just dismissed. And parents don't know enough that they can push for their child, no matter what their functioning level had been prior to this.
Yeah, it's very tragic, I think, for some of our families in that situation where it's kind of being chalked up to tantrums and meltdowns and like that sort of psychomotor agitation and some of the symptomology that they come in with, or often they present to ER. We'll get into that. And then that's maybe not the best place to go first, because it's hard to do the full workup right there.
Yeah. And I think, Dr. Santoro, you were saying earlier that, as there was more awareness about ASD, everyone was just like, oh, that's what this was, or that's what this is, right? So even this morning, Marla and I were having a conversation. We're like going through the list of our clients that we've come across. We're like, oh, had this happened to this person now that we know about Down syndrome regression disorder, right? So it is like that hindsight kind of like, okay, now we're going to have to go back and see if this is in fact what's happening with our guys over here. Just to stay on the prevalence piece for a little bit longer, I was also wondering, from your experience, can previous autoimmunity, because now our radars are up here at DSR, right? We're trying to inform ourselves. We're looking everywhere, but obviously not panicking and making, being systematic about this, but can previous autoimmunity illnesses be an indicator? Because, alopecia, celiac disease, things like that.
Yeah, and we just published on this about 2 months ago with our Inception cohort of patients that we treated over at CHLA and a variety of other centers as well. And it seems like there is a higher rate of personal autoimmunity, not necessarily familial. So there is something probably quite specific about Down syndrome, but I think it's still early to say, but the rates were statistically significant. And I think that our overarching hypothesis is that there is so many different types of autoimmune disease in persons with Down syndrome that there has to be a common link. And I think that, certainly we can talk about that with some of our therapeutic interventions a little bit later on, but we have to apply Occam's razor here as like, there has to be a central explanation for why this particular group of patients is so predisposed to autoimmunity.
Yeah. And then kind of finally, is there a gender difference? Are males and females equally affected? Hormones play a role into that, especially since you said that this kind of does come online around the pubescent age?
I mean, we've seen that there's an age difference in terms of when they present, but it's actually been quite even, which is not something that you see in classic autoimmune diseases, where it's much more of a female predominance after puberty. But, we do wonder if this is truly related to trisomy of chromosome 21, then everybody has that, and it wouldn't necessarily be modified by being male or female. So we've tested a few patients for hormonal dysregulation. All of it's kind of come back negative so far, but still unclear, but no significant predilection by sex.
Okay, so then let's kind of move on to the diagnostic process. So what tests are used to diagnose Down syndrome regression disorder? And can we diagnose based on anything else other than the inflammatory markers? And I will let you describe inflammatory markers to our listeners, because you'll do it way better than I will.
So the diagnostic process, like we were mentioning, is really to rule out other explanations. There is not one inflammatory biomarker that we've said that, all right, this is present in every single patient who has regression. So for right now, we recommend a variety of blood work. A lot of it is designed, let's make sure this isn't a thyroid problem. Let's make sure it's not a vitamin deficiency. Let's make sure it's not celiac disease, things of that nature. We also recommend an MRI of the brain, specifically a 3T, T as in Tesla MRI, which is kind of the higher power magnet. We found that about 20% of individuals will have abnormal MRIs. And in those individuals, they are much more likely to respond to immunotherapy later on. But when we get MRIs, as we saw with a patient we took care of a few weeks ago, she was actually having strokes. And it's not related to regression. That was actually the cause of that regression that the patient was experiencing. So that's a really critical component. We never like sedating patients for anything, but this is a really staple of something we need to do. Yeah. And then finally, we're recommending an EEG, which is non-invasive. We don't use the EEG to necessarily detect seizure activity, but we're looking to see if there's slowing on the EEG. And that can be, helpful in patients who have had a prior normal EEG to compare. But if this is the first time somebody's getting it, it's not going to be as helpful, because EEGs can be abnormal in up to 25 to 30% of persons with Down syndrome regardless. And then the last test that we are recommending is something called a lumbar puncture. The other term for that is a spinal tap. It's not a fun procedure to do, because we do have to typically put people to sleep to have it done, but it's very, very safe. And this is the most helpful test for somebody like me in neuroimmunology, because your brain is protected from your body by this blood-brain barrier. It's why every time you get sick with a virus, you don't get meningitis, right? We want to keep your brain kind of away from everybody else. So the lumbar puncture actually allows us to get past that barrier and look at the fluid that's surrounding the brain to tell us if there is inflammation or not. And in patients who do have those abnormalities, they're essentially universally responsive to immune treatments.
Yeah. So yes, I'm glad that you brought the lumbar puncture up to it, because just for our listeners that may not be familiar, it's like when you're looking for inflammation, you can look for inflammation through various tests. Lumbar puncture is just one that is very robust and can really give you a lot of information. Did I have that correct? Yeah,
exactly. It's the highest yield of the tests that we do, but it's also invasive, and you know, it's a scary test, right?
And you can, so it's clear for listeners, you can find out information through a lumbar puncture that you can't get from blood paneling, because it's getting to the other side of the blood-brain barrier where you can't access that through just a regular blood workup.
Exactly. And the way to think it is that the brain and the blood are operating on whole different systems, right? And, you know, I think we all know this, right? I mean, when you get sick with an illness, your brain is functioning. You may be more tired, but your brain is still functioning normally. And that's by design. But at the same time, we have to bypass that design to get that high quality information.
Is there anything else about the diagnostic process that you feel like it's important for our listeners to know before we kind of jump into the treatment component of DSR?
You know, I think that the one thing to add would be that, you know, there does seem to be a magic window of when we need to get these tests done to have the highest yield. And we see that there's a big drop off between 2 and 3 years after the symptom onset. Now, I think historically, you know, certainly when we first started evaluating patients with this, some would come in with a decade plus of symptoms. And I think that we did the workup just to be thorough, but the yield was very low. So really time is a consideration, both for confirming and ruling out other etiologies, but also for starting on treatment, right? This is a condition that has had a variety of different therapies, you know, thrown at it, and most of them with some effect. So we want to try to be as quick and timely as possible. And another thing I, you know, advocate families to do is not wait a year to complete the workup. I mean, this is something that can be done in a few weeks, if not a few days, at most major academic medical centers.
And something for families to know is that, though I had mentioned earlier, you want to look for common things that can cause an imbalance in people with Down syndrome, like the thyroid and that sort of thing. But we don't want people waiting too long. So I've had families that say, well, my doctor wants to rule out obstructive sleep apnea, but I can't get a sleep study for 3 or 4 months. Year. I mean, if you things can be done concurrently, but I wouldn't wait too long to look at the inflammatory markers.
Yeah, absolutely. So kind of moving into the treatment options that are available out there. What can our families hope for or look for in terms of a way of helping their loved ones?
I think it depends, right? Like a lot of our workup is designed to say, one, is there another explanation? So the treatment for your child's regression may be a gluten-free diet if we find that they're celiac, right? That's the hope, right? We want easy correctable things. If the workup is negative and the final diagnosis is DSRD, there are a variety of different therapeutics. So psychotropics along the line of SSRI compounds, and these are like antidepressants, like Prozac or fluvoxamine is another common one that we utilize. Those have tended to help with the slowness that some patients experience. They can help a little bit with catatonia. And what we find is actually they help with language quite a bit. And the language thing is very unique because SSRIs typically take a couple weeks to work. And what we find is that often within a week or two of starting them, our patients are having some improvement with language. That's very similar to the adult stroke literature, where when we start antidepressants in those patients, just to help them engage with therapy services, something changes in the brain and language will actually be stimulated. And it's exactly what we're seeing in our regression patients. Obviously, not that they're having a stroke, but there's something about the neural recovery that seems to be different in the response to those compounds. For our patients that have sleep issues or are having aggression or psychosis, antipsychotics have been used. To be frank, they're not my favorite thing. They have a lot of side effects, a lot of sedation effects as well. And I don't think that they're particularly helpful, but need to be, augmented for, the exact type of symptoms that are coming in. We've had a variety of patients get benzodiazepines like lorazepam. That's helpful for the treatment of catatonia, which again is present in about 3/4 of our patients and works really well for that. I do find that the lower doses, right? We always want to start low and slowly creep up to higher high. Yep. At the lower doses, it typically doesn't do a lot. The magic number seems to be around 1 to 2 milligrams 3 times a day, obviously depending on the weight of the patient and everything. But you do have to push it a little bit, which can be uncomfortable for many doctors. And then the last two are really ECT or electroconvulsive therapy has been used quite a bit, and immunotherapy. And that's for us has been IVIG or intravenous immunoglobulin, and a variety of other immunotherapeutics if we get a partial effect with that. But it's very broad right now. And the frustrating thing is there's not a real order with which.
Just going to ask. It's like, what's first?
It's very symptom specific. And I think that that's one of those things where over the last year, let's say, as more patients have come over to our clinic, it's just been every different sort of treatment modality. So it's a little all over the place, but eventually we find something that works for the patient. And being on multiple different therapies at the same time is also something that happens quite a bit.
Yeah, absolutely. And I know that IVIG has kind of been with release of some articles and publications. IVIG is kind of becoming a little bit more commonly known for a lot of treatments for a lot of disorders and illnesses. Would you mind just kind of giving our listeners a little bit of a basic primer on what IVIG is and how it works?
So IVIG is a blood product where it takes all of the protective antibodies from multiple different donors and puts them into one IV administration. So when you donate blood, they take out the red blood cells and they'll give that to somebody who loses blood, let's say in a car crash or something like that. But then they actually filter off those other protective antibodies and pool them together. So even though IVIG is an immune treatment, and we normally think of immune treatments as suppressive of the immune system, this is actually a functional immune boost. And so our patients who get this, it works by a variety of different mechanisms. It helps take out pathologic antibodies if they are present. And we don't know if this is an antibody-driven disease or not. It helps with T cell regulation. So the T cells are the ones where if somebody sneezes on your face, they run out and protect your body. The protective T cells actually go up. And then there's about 50 other downstream effects of the therapy. It's very effective, but we don't know exactly how it's working. And I think that that's something where as we're trying to investigate these biomarkers as fast as we can, we want to find what that master switch is, that master problem, so we can be more targeted with the therapies.
Can I ask you a bit more about ECT? Because I think most people who are listening will have one association with that treatment, and that's, irreversible depression or bipolar. And so why and how does what's the mechanism essentially that allows this to be effective in this group? Dr. Quinn?
Well, we don't really know exactly what ECT does, but it has been long used for treatment of catatonia and is found to be very effective in people without Down syndrome and with Down syndrome with catatonic symptoms. But I don't think that there's been ever been a really clear idea. John, do you know anything more about the mechanism of?
Not for regression. I think that, there's multiple different hypotheses because ECT has been around a very long time. There's multiple different hypotheses that range from basically downregulation of pathologic circuits to increased synaptogenesis, meaning that the neurons are kind of spreading out because they're being stimulated. So I don't think we know, but I think that I always like to include a word of caution about ECT. We're shocking the temporal lobes in a patient population that's already predisposed to the development of Alzheimer's disease. Yeah. So what my biggest concern is as a clinician is that we're robbing Peter to pay Paul, that we're getting some therapeutic benefit, but we may have to pay for it downstream.
Is there a critical timeline? Because you talked about that window of getting those tests and looking for those markers. Is there a critical timeline for treating Down syndrome regression disorder?
Shorter answer is we don't know. With symptomatic therapy, no. So for psychotropics, for antipsychotics, for benzodiazepines, you're treating the symptoms, and I don't think that there's a window where they stop being effective. For the immunotherapy, though, I think that, again, that magic window is about 3 years, that our effectiveness really starts to taper off at that point. But, we're up to having about 100 patients on IVIG right now, and we don't even know how long to keep patients on it. We're still in that stage of infancy when it comes to understanding and coming up with long-term treatment plans. Now, we're about to hopefully get our data together to publish our duration study, where we weaned off patients at about a year on treatment, and we found that 50% we can get off of IVIG and the gains are maintained, and the other 50% we can't. And that 50% that we can't, those are those same patients that have the MRI abnormalities, the lumbar puncture abnormalities, the personal history of autoimmune disease. So we're kind of starting to figure out who may be higher risk versus not for needing long-term treatment, but we're still not there. And that lack of the biomarker is really the one that we need to find as fast as we can. Yeah.
And this leads me perfectly into the next question. You said that, 50% of the people in your current cohort of your data are like the gains, they're regaining some of those skills back. But what does that look like? Like, are they, is it full recovery? Is it partial recovery? Because of course, I'm sure our families that are listening, they just want to know if their kid is going to come back to the way that they were before. So I'm sure it's a very hard question to ask, because obviously you said it's in infancy, but what are your thoughts on the recovery and what could be expected?
But I think that it's variable. I don't think that IVIG on its own, is the solution for every patient, right? This goes to what is the etiology of regression? And it's probably different for different patients. So we've seen efficacy from as low as 10% improvement for some patients, all the way to probably 95%. I think families are very hesitant to ever say 100%, because I think that signals that we should, back off the accelerator a little bit. But we get many patients close. So I'd say, our median is probably about 60 to 75% return to baseline. And that's when we add on the symptomatic treatments to see if we can kind of just push people a little bit closer to those prior functional statuses.
You see a differential between your patients who had a dual diagnosis already? Are they making the same gains as your single diagnosis group, or is it additional diagnosis dependent, or maybe we don't know yet?
It's still hard to know. I mean, we probably only have about 10 patients that we've seen who have definitive dual diagnosis DSASD, but they've actually been very responsive.
That is great news.
Even probably more so than our higher functioning patients. And maybe it's that there's a less of a hill that you have to climb to get back to the baseline. I don't know, but I've generally found that has been a particularly responsive population.
A couple of our clients at the DSR who are kind of going through this journey right now, and I forgot to ask this when I was asking the prevalence question, but there's this thing with a lot of them where these things start to happen during COVID, right? So there's this situational environmental context that's kind of, what are both of your thoughts on the impact that something like a pandemic can have in the case of regression?
Well, we know people with Down syndrome like their routines.
Yes.
And they like to be, the majority of them like to be social, and they like to be out in the community. And I think the pandemic was very difficult for many people, including those with Down syndrome. And so I think that can start a type of stress on them that might kick off this sort of regression.
So if the predisposition's already there, and then the environment sets up a further triggering situation, then, but we don't know what the predisposition is, I think is the real challenge. Right.
As with many conditions, that is the case where you have the biological predisposition and then the environmental trigger to make things happen.
And to steal from the psychiatry literature, the concept around that is called diathesis stress, that you're already predisposed to develop, let's say, this autoimmune disease or regression in general, and there's just something that tips you over the edge. And, if you go into other neuroimmunology literature, that is quite frequently reported. So many patients, for instance, who have multiple sclerosis, their first attack will be preceded by some life stressor. And it's not that the life stressor is causing their multiple sclerosis, it's giving their body that final push off the cliff to actually develop the clinical symptoms. It's something I've wondered a lot with, our regression patients is how do you possibly tease out, what is psychologic, psychiatric, and then neurologic? And we've done our best with the existing tests that we have. But ultimately, when we're looking at that picture, after we get all the testing done, we're looking at the pattern. There's not that one test that says, this is the one, and this is why we have to treat them. So some of it, is likely that we will overtreat. And that if the symptoms are getting better and we're not really doing anything, as we've seen in some patients with regression, historically and actively, is that there are some patients that just get better on their own. And it's unclear, again, if this is just a one-time monophasic relapse or, non-relapsing condition that is immune driven, or if it really was just depression that was transient. And that's the thing is, I think the largest problem that we're encountering right now is when that patient shows up to clinic, how do we determine who's going to get the full Monty workup and who are we going to watch and wait? And I think I'll just use this as a, general statement. I think I'm pretty smart. I'll give myself as many pats on the back as I can, but I am so wrong when I think, and I use little language in my note to indicate exactly what I think we're going to find. We do the lumbar puncture studies and I'm sitting there like, what, how is this patient possibly pan positive for all of these different abnormalities? And then we treat them and they get better. Whereas I'm walking into that thing like, the older brother just moved away, family's getting a divorce. Like, of course, this is going to be just depression or, acute stress reaction. And I'm probably 50-50 at best in terms of determining who up front is going to have an abnormality versus not. And I think that we really need to think about that and not bias it by kind of what we believe is the physician or the provider is going on with the patient.
I think that's hugely important, particularly for our group who can't necessarily communicate, right? So they can't tell us, I'm feeling really down. I'm feeling very depressed. I mean, I've never heard it from a person with Down syndrome to date. We can't know. We can't know. And if you can't figure it out, then the only thing we can do is test people and find out that way.
Yeah. I think that's the challenging thing with anything that requires a diagnosis of exclusion, right? Like if you think about issues with digestive problems, like digestion issues is because there's so much overlap, there's so much similarity, and you really have to tease it apart and kind of treat symptom by symptom to see what it is. But
so that's why we recommend having a pretty low threshold to test for different medical conditions in people with Down. So to the point where we actually recommend regular screening for some because it's so difficult to tell to make those diagnoses. So that's why we say if a patient presents with a change in behavior, then get that celiac screen because they may not be able to tell you my belly hurts and that sort of thing. So I think the situation is the same here. It's hard to tell up front what you're going to find when you do the testing.
100%. And I think it's many families will probably agree with this, that there's very much a paternalistic approach to care of persons with Down syndrome. And in that, like, well, we don't want to put them through all of this extra harm with these tests. I mean, it's something that we hear a lot. And, it's not just persons with Down syndrome. Again, it's genetic diseases, intellectual disability, not otherwise specified. But like, if these tests are going to help potentially answer a question, we have to get them. We have to get them quickly. And I think that's the scariest thing for me is, is always the hypothesis that I run by in the back of my head is, what if I'm wrong? what's the impact if I think it's just depression and we're just, see in 6 months versus we are missing something potentially autoimmune or potentially a stroke. That was the scariest one for me, even though this patient showed up and we caught it and excellent outcome as expected. What if we just said that it was depression and we sent them out the door? That patient had no focal findings. We did a thorough neurologic exam and found nothing. And that's the scariest thing for me, is that if we're able to find something early, whether it's stroke, regression, celiac disease, all of these things have better outcomes if you find it early and treat it.
And I'll speak for so many families that I've talked to. The idea that there are some, the tests are scary, and an LP is invasive. But I think most families, even if there was a 1 in 10 or maybe even a 1 in 100 chance of finding some information that will direct treatment to get their child back, I think that they're all in. The difficulty is convincing healthcare providers of that. I just think the consequences of not catching this early. This isn't like being told, your child has celiac disease, or even being told, as scary it is, that your child has a congenital heart defect that needs surgery. This is just a devastating diagnosis for families. And, I have families that say, their life is divided into, the pre-regression and post-regression. It was that significant of an event for them. So it's, I think, parents, it's important for them to advocate for their child and to find healthcare professionals that will listen to them.
You've led me perfectly to my next question for you, which is, what pathway or what professional do you recommend? Who do you see first? Do you present to emerge? You go to your family doctor who knows you better. Mind you, in Canada, we have a bit of a different system than you do. Do you try to go directly to neurology? Where do you aim your advocacy for best effect?
I mean, I always say go with who you know, right? Because if you've gone to the same pediatrician for a decade, they're also going to know that your child is not well, that there's something going on. I think that the care from a multidisciplinary team is really, really important, because we all have certain ways that we look at things, right? Like a psychiatrist will look at things from a psychiatric perspective. I will look at things from a neurologic perspective. Dr. Quinn will look at things from a developmental and behavioral perspective, right? But really, centers that can get everybody at the same table or get multiple evaluations in short order, that's really what is most important. I think that that's ultimately why we've been able to make progress with this condition, is really collaborating with our psychiatrists, with our pediatrician networks, with our, immunologists even, to get that right workup. And it's a complex thing. I've had to prescribe more psychiatric medications than I'm comfortable with, but we don't have outpatient psychiatry, right? So I think that it's not built for any one type of doctor, but really using that pediatrician or the internal medicine doctor as the quarterback for the team, and then bringing everybody to the table.
I always have a lot of learners, medical students and residents with me, and I tell them that their experience, especially in this day and age when people have access to so much information, is that they have to get comfortable with the fact that they might have a family that knows more about a certain condition than they do. And that's okay that you don't know about it, but what you have to do is be open to what the families are telling you. So to be able to say, give me the information you have. Did you get this from some questionable website? Or did you get this from a trusted source? But I really encourage our learners to get comfortable with the fact that there are going to be families that know, and to not take that as an insult or that these are pushy parents, but really listen to the family and evaluate the information they have and evaluate it in the context of what's going on with their child. And I realize I'm putting parents in kind of uncomfortable situations where they have to be the person that finds the information and advocates. But at this point, with where we are with Down syndrome regression, that's kind of where we are. It's many families have happened upon some information and been able to take that to their doctor, and they are the ones that are driving the advocacy for for their child.
Mm-hmm.
And it's one of the reasons that we made our publications on this topic open access, so that families can Google it and find it and bring it in, and they don't have to have a subscription to an academic, library system or something like that, because this is something that takes a lot of advocacy on the parents' end of things or the caregivers' end of things, and it's not fair right now, but we're getting there. We've made tremendous strides in the last 2 years on this. And I've talked to physicians from as far out as Hawaii and as far east as Spain, I think at this point. So we've really expanded the knowledge about this, but it's very grassroots, and it's going to take a lot of families pushing. It's going to take a lot of physician education, provider education, but we're moving in the right direction.
Mm-hmm.
Maybe the OTs and the SLPs listening can also jump in on this as well.
and
kind of
I think we tend to, right?
Yeah.
Because we're the ones who initially confirm, like, this is not your child's normal, right?
Yeah,
like, I have never seen this from your child, and like, we should probably look at something. And sometimes it's the easy answers, right? It's the bad ear infection. It's the constipation, right? It's not always DSRD, but when we see things that look off, it's our responsibility to do something about it. I think what we'll do is we'll put your open access, your expert consensus on our webpage, because that gives a really nice rundown of the testing and the tiered testing approach that you guys have agreed upon. And we'll put your article, which I think is from like maybe April or May, on there too. Are there any other recommended resources that you would like families to have access to that we should put on our page?
Yeah, we created a document called Quick Facts that is basically caregiver focused. So it's not medical jargon. It's just, here's what we know right now. Here's some resources that we can connect on. And that should be available through the DSMIG, DSMIG-USA website as well. And if anyone needs a copy of it, they can also email our research line, which is dsresearch@chla.usc.edu.
All right, we'll put that on our.
Often direct people to the Adult Down Syndrome Clinic at Advocate Medical Group, Brian Chacoin's group. They have a wonderful resource library, and they actually have a section on decline in skills and regression, and they have a number of the articles, and they have the DSMIG consensus statement. So as well as being on the DSMIG website. I will also mention that I have a Facebook group for families who are dealing with regression. It's right now we have this group is a private group for only families that have a loved one with Down syndrome and regression. We do realize the need to develop a public page for people who want more information, but I do feel that if people look into Down syndrome regression, you will find a number of resources. But this page has been, I think, very helpful for many families. You mentioned at the beginning about the isolation that many families feel because this isn't that common in people with Down syndrome, and it is such a devastating condition that I think it's been very helpful, both from a moral support aspect for families to be able to talk to each other and what they're going through, but also from an information standpoint as far as discussing what resources and which healthcare professionals were helpful. Yeah, so the name of the group is Regression and Down syndrome, but I do want to caution that at this point, the members have felt that they want to keep it private and a little bit more of a manageable group. We do have over 1,200 people. It's also open to healthcare providers who treat people with Down syndrome. We want to spread the word about DSRD and information as much as possible. So certainly open to any medical professionals who would like to join.
Thank you. Yeah, from I think Hannah and I's clinical experience, when there's a family going through this, they've taken a decade or so to build up a small community of other families who have kids with Down syndrome who are kind of going through the same things as them. And then this happens and they don't know anybody else who's gone through this. And it's extremely isolating, not to mention that the person that you're now with, your own child, is foreign to you, and you can't relate. So I think it is devastating. even to not be in it, but to watch that happen to a family is horrible. So this kind of group goes a long way. So
as a plug, Eileen reminded me that I had reached out to her 2 years ago on Facebook because I saw the group, and I said, look, we're seeing patients with this. Can I join? Can I post? And she let me in, and I think we talked like the next week or something. So it's a weird way to connect in the medical community, but it's been very fruitful so far.
Very fruitful collaboration. Yeah, I am not a social media person, but because of my experience with my own daughter, and I was on a panel discussion at DISMIG, I think back in 2014, that other Down syndrome clinic directors, when they would encounter families and patients with this, they often reached out to me and said, can you talk to this family? And so I spent a lot of time on the phone with families, and then I thought, I don't want to do this, but I'm going to start this group for families. And it started a little bit slow, and, we probably had 5 families, and then 10, and then 20, and then it's just grown exponentially recently. But it was an interesting, I knew so little about Facebook that I kind of randomly one day, about 2 years ago, they said, what's this little icon, this blue circle with a little wavy line on it? And I pressed it. It was the first thing that came up was this Dr. Santoro reaching out and saying, I'm a neurologist and I'm kind of interested in this. And do you think I can post my information on the page and answer people's questions? And I'm like, I need to talk to you immediately. But I will say something that I have not told John before, is we set up a time to speak a little later. And I'm like, I'm going to check this guy out. And who is this Dr. Santoro? I'm very protective of the families in the group. And I'm like, I got to make sure this guy is legit. Real? So I Googled him, and he did not put in his biography at the beginning, but I Googled Jonathan Santoro, and I get, I think he's going to be okay. Tulane Medical School, Stanford for his neurology residency, Harvard for his neuroimmunology fellowship, and now he's at Children's Hospital LA. I'm like, okay, I'm going to let him in the group.
It's close.
And he has been a fantastic resource for families. And I will say, I know he spends a lot of time on the phone with other providers throughout the country. I mean, many families have gone to LA to meet with him and have their child evaluated. But, he's been wonderful as far as working with other healthcare professionals. So people who don't have the means to come see him can get information about the kind of workup that needs to be done and get treatment locally. So I have to put in a plug for John. I tell you, he's been
You're making me blush, Eileen.
You both deserve plenty of plugs and plenty of praise because
you're celebrities here.
You're celebrities here. You're bigger celebrities now after this for us both, for sure. But I just think it's, like you said, Eileen, it's just such a devastating experience for families. But it's so, I'm hoping that families find some ray of hope in knowing that there are people on their side. There are people working to figure this out. And there are, advancements being made, and that it is now on the map, because I think that's when you feel more isolated when nobody's talking about it.
Super exciting thing is that I think we're getting there. And so I think that's so helpful for families to know that there's hope on the horizon. And, so my message for families often is never give up. Don't accept people. I had one healthcare professional when I was on my journey with Sarah just say, well, can't you just live with this? I mean, she was a little improved, and I just thought, well, wait a minute, you would never say that to me about my other daughters who didn't have a cognitive disability. It's like, no, I can't just live with this because she's not happy. And so I continued on the journey seeking answers, and I think that's important for families to know that you don't have to listen to the professionals that they may be telling you to give up and accept things. But on the other hand, also know that this is a marathon, not a sprint. So you really need to take care of yourself, and you need to rely on other people if they offer help. And you need to, when you've advocated and advocated and you need a breather, then you got to take a break, because, you're the most important thing. When a plane encounters difficulties and the oxygen mask drop down, you have to put the oxygen mask on yourself first, because if you're burned out, you're not going to be able to help your child. So you got to pace yourself, but always always have hope and never be afraid to ask questions and seek more answers.
Thank you both for coming. We hugely appreciate your time. We know you're both very busy finding answers, and this information is very, very important to have available to families. So we really appreciate your presence today.
Yes, thank you so much.
I'm thrilled to be here. Thank you so much.